All right, I'm also the last thing holding you guys till lunch, so let's get this going. So the concept here is we'll talk about the last part of pulmonary hypertension, the other four groupings. And the reason why, going back to the topic of the first one, it's critical to know which one you have, both because as you treat them very differently and because their outcomes are significantly different. Group 2s tend to do worse because they have a lot of left heart failure and require transplants or other things, and sometimes you can't fix it at all. So what I'm going to show you is that most pulmonary hypertension that's not group 1 doesn't get treated with medicines. So the first thing here is, again, this is now considered post-capillary pulmonary hypertension. Again, pulmonary vascular resistance greater than 3, but the key difference is that you have a wedge pressure greater than 15. And this just tells you that this is a left heart obstructive lesion. Now in the adult world, this is the single most common cause of pulmonary hypertension, more than half, and it's typically from HFpEF or HFrEF. And the fact is that, again, we consider the diagnosis as a PVR greater than 3, but the mortality morbidity starts to increase at just a PVR of 2 when we're talking about transplant or mitral valve repair, et cetera. So here's how the physiology develops, or the pathophysiology develops, is if you have a left heart obstructive lesion, you have retained pulmonary venous pressures that results in pulmonary edema chronically. That results in chronic hypoxemia, chronic hypercarbia, and chronic pulmonary edema, or chronic pulmonary vascular resistance elevation over time. If this isn't a disease process where you can get rid of the left heart obstructive lesion, as in you can repair a mitral valve, or you can repair cor triatriatum, or you can do a heart transplant, this will recede, and this over time will recede as well. But the perioperative period can be very challenging. So as we've talked about in the prior work, we've got to do a cardiac catheterization, which in the setting of concern for left heart obstructive lesions, we just have a couple different considerations. You have to have accurate pulmonary capillary wedge pressures. If they're inaccurate, the whole case is useless. And so, it's totally critical that you have the right people doing your studies that you can trust. You should do them bilaterally in case you have pulmonary vein disease. If one side is elevated and the other one's not, that makes you think that this is not a left heart, but more of a pulmonary vein problem. If the pressures are greater than 15 or so in a child, it's worth getting a left ventricular end diastolic pressure as well, because in most cases they will be the same. But if you have a pulmonary vein problem, or you have mitral valve stenosis that you couldn't tell by echo, or you might have an obstructive cor triatriatum, that would be a very different process and would be a very different intervention. And then if you, if you're getting a wedge pressure that is not elevated to the point where you would call it a group 2, but you say, God, I know this guy has left heart obstructive lesion. I know this is a left heart problem. Give him volume. You need to be careful because you don't want to put them into flash pulmonary edema by getting a whole lot of fluid. But the idea being is that, your end diastolic pressures it's a volume and compliance issue. And if you're a third case in the day and they're dehydrated, their wedge pressures will be falsely low. And then lastly, if you now definitively have left heart obstructive lesions, you clearly have a wedge pressure greater than 15, your pulmonary pressures are elevated. The concept of assessing for acute vasodilator testing, it is also still very important, which we'll see again in a second, because it helps you know what your postoperative period might look like, but it's not without risk. Giving somebody who has a consistent left heart obstructive lesion a pulmonary vasodilator, if you overcome, our medicines are much stronger than the autoregulation of the lungs. If we give them nitric oxide, or if we give them sildenafil or Flolan, that will actually decrease that pulmonary vascular resistance, and you will shove a lot more blood into that obstructive region there. The issue is, well, let's see. So let's kind of look real quickly at why this is a problem. One of the first uses of Flolan, one of the most powerful pulmonary vasodilators we have, is looking at its use in left heart obstructive lesions, in left heart failure, I should say, because it does cause systemic vasodilatation. The problem is if you use this in somebody who has a fixed, a LV failure kind of thing, they die. They stopped this first trial with Flolan because a large portion of the patients who were getting it were dying from flash pulmonary edema. So the idea being is, if you don't have anything that you can surgically do for somebody who has has group 2 pulmonary hypertension, don't just start them on pulmonary hypertension meds. You will make them worse. There's clear data for this. If their right ventricle is failing and you feel like that's out of proportion or like that is more of a symptomatic, it's worth trying low dose and slowly ramping, but don't start it just glibly. The next thing is, if you have a disease, you know that you have group 2 pulmonary hypertension and you have a disease you can do something about, well then it's worth talking about doing the vasodilator testing with the caveats I said before. But generally what we will use is a pulmonary vascular resistance after vasodilator testing of less than 6. I talked about this in the last talk, but typically if you can get their pulmonary vasodilator testing and have a PVRI less than 6, they are a reasonable surgical candidate. It's high risk regardless of how you do it, but it's not a terrible idea. So just you've got to kind of prompt the family and the patient to recognize the postoperative period is going to be a challenge. And then lastly, if you have a group 2 pulmonary hypertension, left heart lesion problems, and they have a pulmonary vascular resistance that is greater than 6, despite acute vasodilator testing, if it is from something like left heart failure, whether it's diastolic or systolic failure, if you can put them on either milrinone or some other sort of inotropic effect, or if you can put a ventricular assist device in them and then reassess about 3 months later, such that you now hopefully have had end diastolic pressures that are normal, which you then reduce that end diastolic pressure problem and the backup of pulmonary venous fluid, and hopefully you reduce the chronic hypoxemia, hypercarbia in the lungs, you may have reversed their pulmonary hypertension. And if you can now get them to a PVRI less than 6, it's reasonable to move forward with surgery. If you can't, it's not. So, group 4, I'll say one sentence about this. This is the chronic thromboembolic pulmonary hypertension patients, and these are also patients who have basically diffuse blood vessel narrowing. This is not a disease of the pulmonary arterioles. This is not a disease that responds to medicines. It needs surgery. It needs surgery and anticoagulation. The CTEPH patients, you need to do the subsegmental resection and pull out all the little clots, put them on anticoagulation. Pulmonary vasodilator meds do nothing. They won't hurt you. They just don't help you. It's expensive and useless. So, that's right ventricular hypertension, not pulmonary artery hypertension. Group 5 is another one I won't spend much time with, especially in the interest of time, but the bottom line is this is the kind of the complex ones, kind of the grab bag of pulmonary hypertension. We see this in patients with single ventricle, Fontane's, Glenn's, these kind of things, where the actual pulmonary vascular resistance of 3 is a very challenging one to actually get. It's hard to measure anything in somebody who has some of these more complicated anatomies because you have different sources of blood flow, etc. So we'll typically use a gradient, just a transpulmonary gradient of greater than 6 as an indicator that you have pulmonary hypertension. And in somebody with a Glenn or a Fontane, it may help, sometimes it doesn't. We also, the other parts where we talk about these are patients who have, this falls into this as moya, which is something that you guys see a lot more of than probably anybody else. And when they have secondary pulmonary hypertension, it's terrible. It's a terrible, terrible pulmonary hypertension. It's so progressive and difficult to treat. But they do, in truth, act more like a group 1. You treat them aggressively with meds and just hope. But it's a bad disease. All right, this is the one I want to spend the last real amount of time on. So group 3, this is the lung disease-induced pulmonary hypertension. In the adult world, this is made up almost entirely of emphysema and COPD, right? We know that in that patient population, starting them on a systemic pulmonary vasodilator, sildenafil, endothelin receptor antagonist, any of the prostanoids, it makes their gas exchange worse. We're going to kind of cut through these. It makes their gas exchange worse. I got way too ahead of myself. It makes their gas exchange worse, which I'll show you a little cartoon of in a second. But the idea being is that you have to treat the underlying problem. It's a lung disease problem. You need to focus on making the lungs not continuously scarred, not continuously injured, and not worsening with their gas exchange. Putting them on a systemic vasodilator will make them worse, and I'll show you why in a second. We know that about 2/3 of kids born under 29 weeks will develop BPD, 1. 2 is we know that if you have pulmonary hypertension secondary to bronchopulmonary dysplasia, you have a 2-year 40% mortality rate. So diagnosing those kids correctly and early and treating them correctly and early is critical. And this is why. So look at this guy's lungs. This is a patient with, who knows what's going on up there. We've got some cystic changes over here. We have maybe 12 alveoli that function normally, right? And the things that make these continuously worse are being on the ventilator. I won't go into to the physiology of this too much, but the long and the short of it is that your lowest pulmonary vascular resistance is at your functional residual capacity. And if you're on a ventilator, if you have severe chronic lung disease, you haven't seen your functional residual capacity since the fetal life. So it's a problem. They're living with high PVR all the time. If they're chronically aspirating, it's a problem. If you have chronic infections, it's a problem. All of these things that make your lung function, your lung parenchyma and gas exchange worse is terrible. This one is one that in the cardiology world is obvious. We know that left to right shunts, whether it's a PDA or an ASD or VSD, they're bad for the lungs. It's terrible. You have increased fluid in the lungs and increased pressure. Our neonatology colleagues are slowly coming around to this conclusion as well, recognizing that what they have previously considered an unimportant PDA or an unimportant ASD may actually be important. This has been a lot of work that I've done over the last several years, and just these 3 papers I'll show you real quick basically show that in the US, one of the things that we commonly do is if you are a premature patient diagnosed with chronic lung disease, which typically occurs at 36 weeks gestation. We screen them with echocardiograms looking for pulmonary hypertension because of the terrible outcomes with it. So what's the use? Well, one, we found that if at the time of your screening you had an elevated BNP in this setting, I think it was over 400 if I recall, and or you have any evidence of right ventricular failure at that time, the odds of you having pulmonary hypertension when you are discharged and subsequently having a 40% mortality rate is very high. Second, if when we diagnosed you with pulmonary hypertension and you, again, we showed this with a different group, different set of patients, if you had RV failure or if you had an ASD, the likelihood of having pulmonary hypertension and having a 40% to-year mortality rate goes up. And then lastly is when we compared a bunch of patients who had chronic lung disease and we had a group that had ASDs or PDAs and a group that didn't. They had the baseline same basic chronic lung disease. If you could go in and close those lesions, their ability to improve their lung function, or as Dr. Shrofsky was talking about, the respiratory severity score, improved markedly. So sometimes you almost wish that they had it, so it would be something we could intervene on. Now, so I'll kind of draw these out just so we can kind of see a mindset here, because last time I gave this talk, I got excited and got ahead of myself. So when we're looking at a baby with chronic lung disease that we're screening for pulmonary hypertension, do they have it? No. Repeat it in a month. It's easy, right? Do they have it? Yes. Did we do anything to them recently that could be causing their lung function to be worse? Did we start feeding them by mouth? Did we start changing from an ND to an NG tube feed? Did we start weaning their respiratory support? Did we, and we have pulmonary hypertension? Yes. Well, then go back to what we were just doing and reassess. My goal, I probably start medications on these patients less than 10% of the time. We're constantly looking to just make their lungs better. So have we made any recent changes? If we didn't, okay, now let's talk about this for real. If they've got pulmonary hypertension, yes, but do they have RV failure? And by RV failure, I mean, does it look terrible on the echocardiogram? Is their BNP severely elevated? Do they have big hepatomegaly? Are they not growing? If the answer is no, just leave them alone. They've got bad lungs. We know they're going to have pulmonary hypertension. Just make sure their lungs are healthy, make sure we're doing everything we can to optimize oxygenation and ventilation, and stop making things worse. I can add meds and make this worse, right? But if they have RV failure, fine, we'll do something about it. This is the only scenario in which I add meds. They've got pulmonary hypertension, we haven't changed anything recently, and they're dying. Okay, then we'll start it. All the other scenarios, if you leave them alone, they almost always get better if you focus on lung health. It's just the most critical part of this. Now this is why I don't start meds, and this is the cartoon version of what happens in people with chronic lung disease. So in the 20 alveoli that are working over here, this is what it looks like. Is you've got deoxygenated blood flow coming in, starts getting oxygenated, and it comes out oxygenated, and it comes back to the left side of the heart just fine. right? That's great. If I give them nitric or I give them oxygen, it only makes it better. That actually optimizes VQ matching to the lung segments that work, because oxygen and nitric will only go to functioning lung segments. To the lung segments that are atretic or to the lung segments that are big dilated alveoli that don't work, it won't go there, and so who cares? I can even, in patients who have totally normal lung segments, if I give them sildenafil systemically, that lung segment will work better. Great. The problem is this is just this segment that works well. All the rest of this looks terrible. So let's talk about the diseased lung segment, the one that's full of garbage and that can't oxygenate or ventilate. What happens when I give them oxygen or nitric oxide? Into the rest of the lungs, nothing, because those lungs are not contributing to gas exchange in any sort of meaningful way. So it doesn't matter. I'm not hurting anything. Nitric's not helping anything, and it's really expensive, so that part's a hurt, but it's really not doing anything. But what if I give them sildenafil or bosentan or Flolan, something systemic? My meds are significantly stronger than the autoregulatory function of the lungs. And so I will have blue blood come in and stay just as blue as it came in and come out desaturated and hypercarbic. So I will make them worse. Now, if your right heart is dying, sometimes you have to do that, but you have to recognize when you talk to your neonatologist, you say to them, this is robbing Peter to pay Paul. You know, this is a risk-benefit issue here. I may make things worse, but you have to accept that, and I'm only doing this because I feel absolutely obligated to do it. So this is why I don't start these meds if I'm not forced to do it. So, you know, this is kind of back to the group that we were talking about. There's a lot of different ways that you can get this. You have to always have in the back of your head. The other thing, if I get this exact same patient in a full-term kid, if I meet this kid later and they say, oh, he's got pulmonary hypertension, he's got bad lungs, but he was not premature, he's got a lung disease. He's got something that is probably irreparable and is going to need a lung transplant, or he's probably not a survivor. So in summary, the initial evaluation remains critical. Again, if you got nothing out of this, get that, please. Knowing what you are treating is the single most important thing in patients with pulmonary hypertension. It's what matters the most. And so optimizing your therapies, whether they be surgical or medical, is the most important thing you can do for a patient that you've diagnosed with pulmonary hypertension. There are some things we can do from a transplant and a surgery perspective, but they're a big deal and they're end stage. The last part is that you gotta be realistic with your families. You have to know what the outcomes are because they're not good. They're not good in general. Some of these patients you can do better with, and it's critical to give them everything you can, but being upfront and honest about what you think your expectations are to make things better is critical, partly because in families who aren't particularly good at taking meds or following your orders, letting them know that the alternative is likely death, it kind of tends to make people more encouraged to do what you ask them to do. So thank you very much.